The contents of our lecture today is about the orbit, the eyelid, the lacrimal system, the eyeball, and extraocular muscles with nerve and blood supply within the orbit. The bony orbit are pyramidal bony cavities on either side of the facial skeleton. Each orbit is made up of 4 walls and apex. The apex is located posteriorly, the 4 walls superior, inferior, medial, and lateral, and the base is the anterior part. The orbit contains within them the eyeballs, the surrounding extraocular muscles, nerves and vessels, and orbital fat with different tendons, ligaments, and fascia. The superior wall, or the roof of the orbit, is made up of number of bones, which are the orbital part of the frontal bone, and posteriorly the lesser wing of sphenoid bone. So these two bones make the superior wall, or the roof. Anterolaterally, within the orbital roof, we have a fossa for the lacrimal gland, while the medial wall is made up of 4 bones: ethmoid, frontal process of maxillary bone, lacrimal bone, and also the lesser wing of sphenoid bone. Here we have to pay attention that we have another fossa in the medial wall for the lacrimal sac. The superior wall holds the lacrimal gland, while the medial wall holds the lacrimal sac. The bone forming the medial wall is paper thin. We call it lamina papyregia. Lamina papyregia is perforated by many foramina for the transmission of nerves and blood vessels. That's why orbital cellulitis, which is infection within the orbit, is secondary to ethmoidal sinusitis because of this lamina papyregia and its foramina. The lateral wall of the orbit is made up of another set of bones, frontal process of the zygomatic bone, and the greater wing of sphenoid bone. We know the sphenoidal bone is made up of body, lesser, and greater one. They all contribute to the bony orbit in some particular way. The lateral wall is different from the medial wall. The medial wall, we said, it contains the thinnest bone in the body or in the orbit, while the lateral wall contains the strongest and the thickest bones in the orbit. The lateral wall, the posterior part of it, separates usually the orbit from the temporal lobe of the brain and middle cranial fossa. We come to the final wall, the inferior wall, or we call it the floor. The floor is formed mainly by maxillary bone, zygomatic bone, and small contribution come from the palatine bone. The inferior wall is the same, let's say it's a joint structure between the maxillary sinus and the orbit. It's the same. The apex of the orbit is the most posteriorly located, contains the optic canal, which is situated in the lesser wing of the sphenoidal bone, and contains superior and inferior orbital fissures that we will discuss next. The superior orbital fissure, as we said, is a slit like foramina. It separates the orbit from the brain, and it lies between the greater and lesser wing of sphenoidal bone. Its importance, as I said, it's something like a foramina, so it transmits number of structures to the orbit. These structures are very important to know, which are, we divide it into superior portion and inferior portion. Its superior portion contains lacrimal nerve, frontal nerve, and trochlear nerve, together with superior ophthalmic vein, while its inferior portion transmits superior and inferior division of the third nerve, oculomotor nerve, the abducent nerve, and nasociliary nerve, together with some fibers of the cavernous plexus. These are very important content you need to notice. While inferior orbital fissure lie between the greater wing of sphenoid and the maxilla, usually at the junction between the floor and the lateral wall. It transmits to the orbit maxillary nerve, zygomatic nerve, and some branches of pterygopalatine ganglion. The thing about inferior orbital fissure, it separates the orbit from the pterygopalatine fossa. Also, it transmits the inferior ophthalmic vein. We said that the superior orbital fissure allows the passage of superior ophthalmic vein, while the inferior one allows the passage of inferior ophthalmic vein. After having full information about the bony structure of the orbit and the content of the apex, we see it on these images. It's very clear. We have the roof of the orbit, lateral wall, the floor, and the medial wall. Each of these walls are composed of number of bones. You also should pay attention to the superior orbital fissure here and the inferior orbital fissure. As I said, the superior orbital fissure, it's a part between the greater and lesser wing of the sphenoidal bone, while inferior orbital fissure between the maxilla and greater wing of the sphenoidal bone. This red large wing at the apex are the greater wing of the sphenoid. We see the optic canal, which is a small foramina within the lesser wing of the sphenoidal bone. Also, the optic canal transmits the optic nerve. This is very helpful drawing for the structure of superior and inferior orbital fissure and optic canal. You see the structures passing through the upper part of superior orbital fissure are superior ophthalmic vein, lacrimal nerve, some meningeal branch of ophthalmic artery, frontal and trochlear nerve, as we mentioned. While structures passing through the inferior part of the superior orbital fissure are superior and inferior division of oculomotor nerve, nasociliary and abducens nerve, together with inferior ophthalmic vein. We usually divide it like this: superior part and inferior part, and each part content. What about the optic canal? Optic canal, as we say, it transmits the optic nerve together with the ophthalmic artery. That's important. The optic canal situated in the lesser wing of the sphenoidal bone, while the fissure separates the lesser from the greater wing of sphenoidal bone. What about here the tendinous ring in this image? Tendinous ring, we come to it later when we discuss the extraocular muscles, especially the recti. Tendinous ring is a fibrous tendon-like structure which surrounds the optic canal and the inferior part of superior orbital fissure. It's the origin of the 4 rectus muscles. The content of the inferior part of superior orbital fissure and of the optic canal all pass within this tendinous ring. We also notice the inferior orbital fissure, which lie between the maxilla and greater wing of the sphenoidal bone, the infraorbital vessels, some emissary veins, zygomatic nerve, and maxillary nerve. What we need to know about the eyelid and lacrimal apparatus are the general structure and function. I mean with general structure, the composition of each and different terms we use. The eyelids are thin skin folds. As you all know, we have superior and inferior eyelid. Their function: blinking, protection of the eyeball, distribution of tear. They act like a shield. Lacrimal apparatus, usually when you discuss the eyelid, we discuss with it the lacrimal apparatus or lacrimal drainage system. Because it is situated within the eyelid itself. What about the conjunctiva? When I say conjunctiva, you have to know we are describing a continuous, thin connective tissue, well vascularized layer, which is semi-transparent. This continuous layer, it envelopes the inside of the eyelid and the anterior surface of the globe up to the cornea. When you see the pictures, you will imagine it better. We have 3 layers in the conjunctiva, or 3 parts, according to the site that it covers. We have the palpebral conjunctiva, the bulbar conjunctiva, and the redundant conjunctiva in between these both, palpebral and bulbar. We call it the fornical conjunctiva. It's the same layer, but the site where it covers give it different name. The palpebral conjunctiva, from the name, palpebrae are the same as eyelid. Bulbar are the same as the eyeball anterior surface. So these are, let's say, some terms we use in ophthalmology. You shouldn't be confused with them. When I say palpebral conjunctiva, I mean the part of the conjunctiva that's reflected onto the eyeball from the eyelid. So the part that's covering the upper and lower eyelid from the inside. And it becomes continuous with the bulbar conjunctiva through the fornicia. As we said, the bulbar, it covers the anterior surface of the eyeball up to the cornea. The cornea is not covered by conjunctiva. And the fornicial is the in-between part. The conjunctival sag is the term given to this space bound by palpebral and bulbar conjunctiva. It's important because they act like a mucosal bursa. It enables the eyelid to move freely over the surface of eyeball as they open and close. This image will give you a better description of the conjunctiva. This is a cross section through the eyelid. We see the eyelashes so that you can imagine where is the cross section made. We see the eyelid, upper and lower, and then the bulge of the cornea and sclera. Now the bulbar conjunctiva is the blue part that covers the sclera. The sclera is the white layer and the cornea is the white layer in the image. And the red part that covers the inside of the eyelid is the palpebral conjunctiva. The joining point superiorly and inferiorly, we call it pharyngeal conjunctiva. The other image is a frontal view of the eye. You see when we pull the lower eyelid downward, we can see always the bulbar conjunctiva. You can try it on each other. Just pull the lower lid downward. You see vascularized pink layer. This is the conjunctiva. The bulbar conjunctiva is the one covering the white part of the frontal surface of the eye, which is the sclera. The cornea is the colored structure here, which is not covered by any conjunctival tissue. After knowing the conjunctiva, which cover the inside of the eyelid and the front of the eyeball, we now can discuss the eyelid itself. We have, as we said, superior and inferior eyelid in each eye. Each eyelid are made up of skin, so skin is not that strong. What they contain is a structure, we call it the tarsus. Each eyelid contains tarsus, so we have superior and inferior tarsi. These tarsi, their function is to strengthen the eyelid because they are dense fibrous layer. Within each tarsal plate, the tarsi جمع tarsal plate. Each tarsal plate contains what we call it the meibomian glands. These are specialized sebaceous, oil secreting glands, located only within the tarsal plate. They secrete the lipid that form part of the tear film and help to lubricate the surface of the eye. What I need you to see in this image is that each of the superior tarsus and the inferior tarsus, which are half lunar structures in light blue here in this image, are joined medially and laterally by a tendon. Superior and inferior tendons medially are joined together and laterally are joined together to create medial canthal tendon and lateral canthal tendon. So each eyelid, as we said, is strengthened by tarsus or tarsal plate. This tarsal plate is being further strengthened or joined medially and laterally by a limb of the corresponding medial and lateral canthal tendon. These tendons will connect to the orbital wall medially and laterally. This will give strength to the eyelid and give the eyelid its proper shape that we all know. The junction of upper and lower eyelid will create medial and lateral palpebral commissure or angles, or sometimes we call it the canthus, medial canthus or medial angle of the eye or medial commissure, and the same for the lateral. As we see here in the image, we have the lateral canthus and the medial canthus. This is the angle where superior and inferior lid are joined. We see the inferior lacrimal papilla and punctum. It's very obvious in this image that there is some tiny opening about 1 millimeter in diameter. This is the opening where the lacrimal drainage system starts. This is where your tear is drained. We call it the lacrimal puncta. This is the first part of the lacrimal drainage system. The orbital septum is very important structure in the orbit. It's a weak membrane that usually attaches itself to the periosteum around the orbital margin and become continuous anteriorly with parts of the eyelid to blend with the structures of the eyelid. The orbital septum, there is fat behind it. During surgery or trauma, sometimes when the orbital septum is opened, we see fat protruding through the wound. So its function is to keep the orbital fat contained posteriorly and limit its spread. Sometimes in old age, when this septum is weak, we see old people have bulging fat around the globe. That's why, because the orbital septum is weak now and cannot hold the fat in its place. The second important function, which is very, very important, it limits the spread of infection when there is infection anterior to the orbital septum in the soft tissues. Because the septum is intact and impermeable for organisms, this infection will not enter the orbit. But if there is any breach in the septum, this infection will immediately become orbital, and usually orbital infection can lead to meningitis and brain abscess. So this is the importance of orbital septum. We will see it in the next image. This image will show you in detail the structure of the eyelid. The eyelid, as we said, are skin folds. So it's made up of skin, and the skin contains lashes, as we see. Within this skin, we have part of the orbicularis muscle in the upper and the lower eyelid. Then comes, after the orbicularis, the orbital the tarsal plate. We have superior tarsal plate and inferior tarsal plate. Within each tarsal plate, as we said, we have a meibomian gland which secretes the oil needed for tear and for lubrication. Now we should pay attention to the orbital septum, as we said. The septum extends from the periosteum and it blends with the structures of the eyelid superiorly and inferiorly. It acts like a weak thin membrane that prevent the orbital fat from protruding anteriorly and limit the spread of infection to the orbit. The lacrimal drainage system or lacrimal apparatus is made up of number of structures we all need to know. These structures usually start as the lacrimal puncti, and we saw their location in the lid margin medially, superiorly and inferiorly. We have two puncti, one at the lid margin superiorly and the other inferiorly. These puncti will lead to the canaliculi. Then the canaliculi will open in the lacrimal sac. The lacrimal sac, as we said, contains specialized fossa on the medial orbital wall. The nasolacrimal duct will drain from the lacrimal sac into the nose. So this is the lacrimal drainage system: puncti, canaliculi, lacrimal sac, and nasolacrimal duct, and the nose. What about the lacrimal gland? The lacrimal gland is the source of the aqueous layer of the tear film. It secretes the aqueous component of the tear film. The tear film is made up of aqueous component and lipid component. Lipid comes from the meibomian gland and the aqueous comes from the lacrimal gland. And we said the lacrimal gland is situated in another fossa in the superior lateral part of each orbit. We have two lacrimal glands. These glands will release their fluid through 8 to 12 excretory ducts, which open into the conjunctiva and release this tear in response to parasympathetic stimuli from the 7th cranial nerve. So any lesion of the 7th cranial nerve might affect tearing process. We have number of muscles we will discuss later on in this lecture and their nerve supply. Injury to these nerve supply can impair the function of the corresponding muscles and result in certain pathologies. Oculomotor nerve, the 3rd cranial nerve, when it's injured, this will limit the supply to levator palpebrae superioris muscle. From the name, levator palpebrae superioris muscle is responsible for elevating the eyelid. So when the nerve supplying it is damaged, there will be ptosis, or what we say eyelid droop. While damage to the facial nerve supply, the muscles of facial expression, including the orbicularis oculi. Orbicularis oculi is the one responsible for closing the eyelids strongly. So damage to the facial nerve will impair this function and impair the protective blinking mechanism of the eye. The eyeball is about 25 mm in diameter. It is composed of 3 layers: outer, middle, and inner layer. And each eyeball occupies most of the orbit. The connective tissue layer that surrounds the eyeball, in addition to the 3 layers of the eyeball, will have additional tenon fascia, or we call it facial sheath of the eyeball, or as we said, tenon fascia is an additional connective tissue layer that surrounds the posterior part of the eyeball and form a socket around it to help lubrication and movement. So we come to the 3 layers of the eyeball. The outer coat or the fibrous layer is the sclera and the cornea. The middle layer or the middle coat is the vascular layer of the eyeball. This is made up of iris, the ancillary body, and posteriorly the choroid, while the inner layer, the inner coat, is the retina, الشبكية. This image will give you an idea about these layers. This is the eyeball, كرة العين. The whitish layer here in this image is the outer coat, the fibrous, sclera and cornea. The pink middle layer is the vascular, which is made up of iris, ciliary body and choroid. And the inner yellow structure here in this image is the retina, which is the inner layer, the sensory retina. The outer coat of the eyeball is the fibrous layer, the sclera and the cornea, which provide the general skeleton of the eyeball. The sclera is the posterior whitish part, and the cornea is the central transparent part. So there is difference in their transparency. One is whitish opaque and the other is transparent. We will know that in the next slide. These are the differences between these two layers, the sclera and the cornea. Why they differ? Although they are continuous. Outer coat. The regularity of the arrangement of collagen fibrils in cornea and sclera give them their color. It's very regular in a particular way in the cornea that will grant its transparent look, while the sclera, the regularity is different. That's why the sclera is opaque and white. The degree of hydration of each is also different. How? The sclera is relatively avascular. When I say relatively avascular, it's almost there is no blood supply, but there is some little blood supply, but it's relatively avascular, while the cornea is completely avascular, receiving its nourishment from where? The cornea receives its nourishment from the capillary bed around it and from the fluids on the external and internal surface, like the lacrimal fluid outside and aqueous humor inside. The cornea is highly sensitive to touch. It's very painful structure. Its innervation is provided by which branch? By the ophthalmic division of trigeminal nerve. So even very small foreign bodies like dust particles will initiate the reflex of blinking and tearing. That's a very sensitive structure. The limbus is the region of the sclera, or let's say the limbus is the junction between these two outer layers. Outer layer parts, the sclera and the cornea. The limbus is the junction between the sclera and the cornea. We call it also the corneoscleral junction. It's about 1 millimeter in width. It's gray in color. Its translucent circle contains superficial and deep capillary networks. These networks in the limbus are the ones responsible for nourishing the avascular cornea. The middle vascular layer of the eyeball is made up of iris, ciliary body, and choroid. The choroid is the posterior part. It lies between the retina and the sclera. The choroid is red-brown layer. It's rich with vascular blood supply, very rich. Within this pigmented and dense vascular bed, we have larger and tiny vessels. The larger vessels are located externally near the sclera, while the fine vessels, which we call the choriocapillaries, are adjacent to the retina so that they can supply the retina with blood, because the retina needs a huge blood supply for the photochemical visual process. The choroid, as we said, is the posterior part of the vascular layer. To continue with the ciliary body anteriorly. Ciliary body is muscular structure. It's a ring-like muscular structure. It lies just posterior to the region of the corneoscleral junction, or the limbus. I see the limbus anteriorly. Behind it, there is the ciliary body. It is circular, ring-like muscular structure that lie behind the limbus. It has certain functions. It connects the choroid with the iris, as we said. It's an intermediate layer. The ciliary body also suspend the lens in a place through the zonules. The zonular fibers attach to the periphery of the lens and they connect with the ciliary body. So through the ciliary body the lens is suspended in a place. Another function, it controls the thickness of the lens. How? The lens is changing in shape with various positions. When I see the distance, the shape of the lens is different when I look at near object. This difference in the shape of the lens is a function of the ciliary body through the process of accommodation. The fourth function of the ciliary body, it secretes aqueous humor. Aqueous humor is the transparent fluid that fills the anterior chamber of the eyeball. These are the functions of ciliary body, which is very important and all of you should know. The most anterior part of the middle vascular layer, the uveal tract, is the iris. The iris is the colored part that you see when you look at someone's eye. Some are brown eyes, some are black, some are green, some are blue. The iris is the one responsible for this different colored eyes. The iris is circular diaphragm composed of epithelium, stroma, and muscles. In the middle of the iris we have central aperture or opening. We call it the pupil. The pupil transmits light to the retina. We have two muscles, as we said, within the iris, voluntary and involuntary muscles, supplied by parasympathetic and sympathetic nervous system. The one that's supplied by the parasympathetic nervous system, we call it sphincter pupillae muscle. From the name, it's sphincter pupillae. So it's responsible for constriction and meiosis of the pupil. While the one supplied by the sympathetic nervous system, we call it dilator pupillae, and it's responsible for dilating the pupil. The inner layer of the eyeball is the retina. The retina is made up of two structures, the inner sensory retina and the outer pigmented retina. The inner sensory retina is typically 9 layers, while the outer pigmented retina is only 1 layer. Between them we have the subretinal potential space. The retina in general is the sensory part. What I mean with that is the one responsible for creating the vision. The fundus of the eyeball. This term, we use it to the part of the inner retina that we can see through ocular exam. We call it the fundus of the eyeball. Some sort of ocular exam, we can see parts of the retina, which is the fundus. The fundus is circular area. فد منطقة نقدر نشوفها when we examine the inside of the eye. During common ophthalmic examination, what we can see is optic disc, macula. In the center of the macula, we can see the fovea centralis, and in the center of the fovea, we can see the fovula. So, we see the optic disc, and just lateral to the optic disc, عندنا الماكلة. الماكلة lutea, or the yellow spot, البقعة الصفراء. It contains central depression about 1.5 millimeter in diameter, which is the fovea centralis. In the center of the fovea centralis, there is another structure about 0.3 millimeter, which is the fovula. The difference between the optic disc and the macula is their process, their function. Optic disc is the physiological blind spot, while the macula and its fovea and fovula are the ones responsible for our sharp colored vision, while the optic disc, it has no photoreceptors. It only transmits fibers, nerve fibers. The optic disc transmits the nerve sensory fibers and vessels, and it carries no photoreceptors. The ones responsible for vision are the photoreceptors. When the disc contains no photoreceptors, so it is insensitive to light. But it's an essential part. It carries information to the brain to be interpreted there. While the macula, the fovea, and the fovula are filled with photoreceptors, and they are sensitive to light and produce the vision, the sharp colored vision that we all have. What about the blood supply of the retina? We are discussing it separately from the rest of the eyeball because of its importance. We said that the optic disc carries the nerve fibers and vessels. Which vessels the optic disc carry, or the optic nerve in general, are central retinal artery and vein. These vessels enter the eyeball through the substance of the optic disc. Central retinal artery is the first branch of ophthalmic artery. Central retinal artery usually supply the inner 2/3 of the retina, while the outer 1/3 of the retina, including cones and rods, which are the photoreceptors, are supplied by choriocapillaries of the choroid. Now let's talk about the division of the eyeball. We said that the eyeball has 3 outer layers. What about the inside of the eyeball? The inside of the eyeball is divided into anterior segment and posterior segment. The anterior segment includes all the structures as far as the lens, and the posterior segment all the structures posterior to the lens. Now, the anterior segment contains anterior chamber and posterior chamber. So anterior and posterior chamber are parts of the anterior segment. The anterior chamber are the space between the cornea and the iris. The posterior chamber are the space between the iris and the lens. The iris, which lie on the anterior surface of the lens, thin, contractile diaphragm with a central pupil, as we said, that allow transmission of light, and 2 muscles control the diameter of the pupil, the sphincter and dilator pupillae. The lens, which lie posterior to the iris and suspended in its position by the zonules, which attach to the ciliary body, is transparent biconvex structure. The lens, transparent biconvex, enclosed in a specialized capsule and attached to the ciliary body through the suspensory ligaments اللي هما zonules. Contraction of the ciliary body will change the shape of the lens and will change the power of the eye. The posterior segment. Now we finish the anterior segment, which is filled with aqueous humor secreted by the ciliary body, while the posterior segment contains the vitreous humor, which is jelly-like transparent substance that fill all the posterior segment and give the eyeball its shape and keep the retina in its position. This image will give you a cross-section of the eyeball that will illustrate all what we have spoken about. You see the pupil, the cornea, the anterior chamber, posterior chamber, the lens, and the suspensory ligaments, the zonules attaching it to the ciliary body. You note the position of the ciliary body just posterior to the limbus location, and the vitreous cavity that's filled with vitreous jelly. We see the 3 layers: retina, choroid, and sclera, and the yellow structure The yellow stalk is the optic nerve. This image will show you what I meant with the fundus. The fundus is the part of the inner retina that we can see through examination. In the fundus, we can see the optic nerve, which is situated here on the right side with the emerging vessels superiorly and inferiorly. And adjacent to the optic nerve is the macula of the retina. In the center of the macula, we have the fovea and the fovula. Now we come to discuss the extraocular muscles of the orbit, which is a very important subject. Extraocular muscles are made up of the levator palpebrae superioris muscle, which is the one responsible for elevating the eyelid against the effect of gravity. We have 4 rectus muscles, superior, inferior, medial, and lateral, and 2 oblique, superior and inferior oblique muscles. For the levator palpebrae superioris muscle, which is the one supplied by the 3rd cranial nerve, at its end, when it ends, it's divided into an aponeurosis. This aponeurosis contains superficial and a deep part. The superficial part blends with the skin of the eyelid, and the deep part attaches itself to the superior tarsus. We call it molar muscle. Molar muscle, or the superior tarsal muscle, is the deep part or the deep lamina of the distal part of levator palpebrae superioris. It attaches to the superior border of the tarsus and it aids in eyelid elevation, but it's supplied not by the 3rd cranial nerve but by sympathetic fibers. The 4 rectus muscles, they originate from the apex of the orbit and insert into the sclera just posterior to the limbus, and they are named according to their anatomical position to the eyeball: superior rectus, inferior, medial, and lateral rectus muscle. Their primary action is also dependent on their location, like, for example, elevation for superior rectus, depression for inferior rectus, adduction for medial rectus, and abduction for lateral rectus muscle. Let's discuss the origin a little bit more. I said they are originated from the apex of the orbit. We said earlier in this lecture, we have the common tendinous ring. The common tendinous ring is the origin of the 4 rectus muscles. It's a fibrous ring that encircles the optic canal and the inferior part of the superior orbital fissure, and it's the common origin of the 4 rectus muscles. In this image, there is the common tendinous ring that surrounds the optic canal. Optic canal transmit the optic nerve and the ophthalmic artery, and we can see a number of nerves also flowing through the common tendinous ring. These are the nerves and the vessels mentioned to pass through the inferior part of the superior orbital fissure. We see the origin: superior rectus, medial, inferior, and lateral rectus muscle. Now we are discussing the oblique muscles. We have 2 obliques, inferior oblique and superior oblique. Inferior oblique muscles, the only muscle to originate from the anterior part of the orbit, I mean adjacent to the orbital rim, حافة الأوربت, just lateral to the lacrimal fossa, the fossa for the lacrimal sac. From this region, at the orbital rim, originate the inferior oblique muscle. From the name oblique, I mean it has an oblique course until its insertion, not like the rectus muscle. Recti usually have origin and directly go to their insertion, while oblique muscle have some tortuous course. How? As we said, the inferior oblique originate from the floor of the orbit, just lateral to the lacrimal fossa, while the superior oblique originate also from the apex, from the orbital apex, superomedial to the common tendinous ring. So outside the tendinous ring, superiorly, slightly medially, this is the region where superior oblique muscles originated. The oblique muscle passes laterally to insert on the lateral half of the eyeball, posterior to the equator. What I mean with this? Usually the recti muscle insert anterior to the equator. Equator are the line cutting the eyeball into anterior and posterior part. Anterior to the equator belong to the rectus muscle, posterior to the equator belong to the oblique muscle. I mean the insertion. Each group of muscles are inserted either anterior to the equator or posterior to the equator. In this diagram, all that you need to know about extraocular muscles is available in a very nice and simple way. The action is what we will focus about here. Let's discuss first the action of rectus muscle. For medial and lateral rectus muscle, they have simple action. Medial rectus adduct and lateral rectus abduct the eyeball. That's it. What about superior and inferior rectus? They have little bit different action. How? They have a primary action and secondary action. Primary action of superior rectus is elevation. Primary action of inferior rectus is depression. What about the secondary action? The secondary action of superior rectus is adduction of the eyeball and intorsion. Intorsion is inward rotation of the eyeball. Inferior rectus muscle, their primary action is depression of the eyeball, and the secondary action is adduction and extorsion, external rotation of the eyeball. The same goes for superior oblique and inferior oblique. They have a primary and secondary action. The primary action of superior oblique is intorsion, and the secondary action is depression with abduction of the eyeball, so it's opposite to the rectus muscle. While inferior oblique, the primary action is extorsion and the secondary action is abduction with elevation of the eyeball. Arteries within the orbit are mainly either from internal carotid or external carotid artery. Mainly we will focus on the ophthalmic division of internal carotid artery, which supply the orbit with these branches. It's very important to know central retinal artery, which is the first branch, supraorbital, supratrochlear, lacrimal, dorsal nasal, short posterior, and long posterior ciliary, posterior ethmoidal, anterior ethmoidal arteries, while infraorbital artery, which is a branch of external carotid artery. Each one of them has course and has different structures to supply. Finally, we have a few notes about third nerve palsy and how it affects the eye. As we all know, third nerve supply levator, palpebrae superioris muscle that supply the sphincter pupillae of the iris. It supply number of extraocular muscles like medial rectus, inferior rectus and superior rectus muscle. So, if there is any damage to the third nerve, there will be manifestations presented as ptosis. Where the levator muscle is paralyzed. Levator muscle is responsible for elevating the eyelid. When it's not supplied by the third nerve anymore, there will be ptosis. And there will be some sort of strabismus or sequent due to rest of extraocular muscle involvement like medial rectus, superior rectus, and inferior rectus, where they are all supplied by the third nerve. There will be some ocular misalignment resulting in obvious ocular deviation. We call it sequent or strabismus الحول. إضافة إلى هطول الأجفان، إضافة إلى تغيرات في بابل العين.